So as everyone in the room knows, the shoulder has three basic bones. There's the humerus, the clavicle, and the scapula. And what we're talking really about, the ball and socket here, is the humerus and the glenoid. The glenoid is the end of the scapula where that ball and socket rotate. And this ball and socket rotation can develop arthritis. There's run-of-the-mill osteoarthritis, which is the wear and tear phenomena with some genetic component to it. Post-instability, so someone who's had a shoulder that dislocates numerous times and hasn't had the opportunity to have that shoulder repaired can develop arthritis. Rheumatoid arthritis, which our medical doctors have really figured out and treated much more effectively in the years. So we see a lot less of shoulder surgery requiring replacement in the rheumatoid population. Rotator cuff tears. When your rotator cuff tear goes unchecked for many years, you can indeed develop rotator cuff tear arthropathy and arthritis from this. Post-traumatic, after fractures, after injuries, after trauma to your shoulder, the shoulder is more likely to develop arthritis. And post-surgical, unfortunately, after some of our surgical operations, arthritis is a higher risk for these patients. As you can see on these x-rays, one has a normal ball and socket with a space between the ball, humerus, and the glenoid, and the other one has an elimination or eradication of that space. And that really is the diagnosis. A diagnosis of shoulder arthritis is frequently made by something as simple as x-ray alone. So when this guy comes in to see me and he tells me he's been working out for the last 68 years and his shoulder hurts too much and he can't do it anymore and he can't sleep at night, we have a very effective, straightforward operation for him. And that's a shoulder replacement. That's taking this shoulder on the x-ray with a spur on the bottom of it with an eradication of the joint space and replacing it with a new ball and new socket. The ball is made out of metal, it goes into the humeral shaft. The socket is made out of plastic and gets cemented into the scapula. And for this gentleman, he will go back to doing push-ups, he will enjoy the shoulder for the rest of his life, and he will eradicate his pain and be very, very functional. And this is a wonderful operation. The weak link, however, in the operation is the socket or the glenoid. This small, quarter-sized piece of plastic has to get cemented into a very small socket. And after 12 or 15 years of use or abuse, it can wear out. Fortunately, in the 68-year-old man, he's not going to use and abuse it the same way that someone like Dr. Vitale might use and abuse his shoulder, so it will last him the rest of his life. But when this guy comes in to see me, or when Dr. Puglisi comes in to see me and tells me their shoulder hurts, my solutions for arthritis are not the same, because if I can avoid putting in a glenoid socket in someone who's in their 30s or 40s, I would like to. So, conservative treatment. Despite the fact that we're surgeons, we actually do try very hard not to operate on most of our patients. An activity modification, saying maybe benching 400 pounds is better than the 550 you've been trying to do. Reduce the weight a little bit. Physical therapy, actually strengthening the muscles and tendons that surround the shoulder. We can't make the therapy can't make the arthritis go away. But if we can strengthen up the shock absorbers, this indeed can help. Anti-inflammatory medication when tolerated. I'm not a big fan of putting someone on anti-inflammatory medication for the rest of their life, but if you can use Advil, Aleve, and these over-the-counter medications to try and mitigate or moderate your discomfort, that's a great idea. Steroid injections are a great Band-Aid. They don't make the disease go away. They can temporarily help you, and we want to limit the number, as Dr. Kessel suggested earlier. Hyaluronic acid injections. This is viscose supplementation. It's not acid we're putting in your shoulder, but joint lubricant. Those are all frequently referred to as WD-40 for the shoulder. This is not yet FDA approved. It's used for well over a decade in the knee, but we have expanded the indications and can push it and have had reasonable results with this. And PRP, as you heard about earlier this morning, the new magic platelet growth factors, this has got some early unstudied promise in arthritis in the shoulder, and this will be something that we see over the next 5 to 10 years if it can indeed be a temporary bridge. There are unfortunately surgical solutions. This is a funny picture. This is Rocky and Governor Schwarzenegger in the same room after they've had their shoulder surgeries on the same day. So these young, strong, muscular men will need shoulder surgery, and we want to look at non-replacement strategies. So what about arthroscopy? In general, when someone comes in to see me and says, I have bad shoulder arthritis, is there an arthroscopic operation for me? I make it very simple. The very simple answer is no. But when they turn around and they're 34 or 35 years old, I need to think of other strategies. I need to think out of the box and come up with other ideas for this problem. So cleaning out the joint fluids, debriding them, releasing the tight capsular tissues, removing the loose floating bodies, getting the biceps out of the way, and smoothing off the bone spurs when needed is a reasonable thing. Here you can see a weightlifter who doesn't really have arthritis, but they've knocked a piece of cartilage off the back of their shoulder, where you can see the blue arrow, and that red arrow shows their labrum. And what I'll do here is I'll cover up that hole. So I'll patch that defect in the shoulder by putting the labrum into the hole in the arthritis, such that that hole doesn't grow bigger and turn into a bone-on-bone arthritis. In other situations, when people have bone spurs, not such massive bone spurs, I'll go in there arthroscopically, and with an x-ray and with the arthroscopy and lots of tools that can make the OR staff a little crazy, I'll shave down these spurs, I'll make them better, and I'll temporarily buy them 2, 5, maybe if I'm lucky, 10 years of shoulder motion and activity in an unrestricted way before they ultimately come to replacement. Microfracture is a technique. Well, we're going to hear more about this from Dr. Delos when he talks about cartilage regeneration techniques. But the idea is to take a hole or an area of cartilage that's missing, make small poke holes, and get that bone, get those bone factors, get those stem cells to percolate up and bring in a fibrovascular cartilage-like tissue. And I can see them here. You can see a picture on one side of a normal, shiny humerus with great cartilage on it. On the right side, the ball is bald of cartilage and has only bone exposed. And what I'll do is I'll make small holes. I'll microfracture that area, again, in a 29-year-old person in this case, to try and temporize the case and try and get them some more cartilage on their shoulder to buy them 5 or 10 years. On the left side, you can see a normal socket, smooth like an egg, perfect cartilage or a perfect Teflon surface. On the other side, you can see pink bone. The cartilage has been completely eroded from multiple dislocations. And I'll make small bone sockets here, small holes to try and get the microfractured stem cells to come out and cause some element of fibrovascular tissue. From the elbow surgeons, we borrowed an idea of what's called interposition arthroplasty. Here you can see an arthritic elbow with that red, the joint facing itself and rubbing against each other. On the bottom, that blue, we put in a piece of fascia, a piece of tissue that we take from another part of the body or a cadaver piece that can act as an interposition or an interface to get some of the rubbing to improve. In the shoulder, we can do this. We can take this piece and sew it back down onto the body. Even more elegantly nowadays, we can do this arthroscopically. So you can see the picture on the left with lots of tiny little holes, little microfracture holes, and then a brand new surface interposed over that. The results of this are okay. Not great, not wonderful, but they are bridges to take young patients, in this case another 26-year-old, take them out 5, 10, maybe 15 years before they have to have their ultimate replacement. Replacement shoulder, when I say it's such a scary word, it does not mean we're going to put a new robotic arm on your shoulder at all, like this picture suggests. There's lots of ways to replace or resurface or put a new cap on. We can use just the topic, just a cap for the ball. We can use an entire stem and socket, or in the most severe cases, and not so applicable to young patients, at least when we can avoid it, we can use a reverse shoulder replacement when the rotator cuff and all the tissues have already been compromised. Just for words, hemiarthroplasty. Hemi is half. That means we're replacing the ball only. A total shoulder replacement in the middle means we're going to replace the ball and socket. And the reverse shoulder replacement is really sort of out there, where we reverse the orientation of the socket and the ball. The socket goes where the ball is and the ball where the socket is. And this is a situation where the rotator cuff has been absolutely ruined and is really unsalvageable from any method that we currently know. We're getting a little more exciting. As I showed you, or as you see in the middle, you can see a long stem that goes all the way down into the socket. Now we're trying to come up with ways to do even less, remove less bone. You can see a cap on one picture here and a surface replacement. So by preserving the patient's bone and preserving their anatomy, we really are trying very hard to trick your body into thinking we're putting a brand new shoulder in. So these resurfacing operations preserve bone. It may be a little harder to resurface the socket, but in young patients, again, the weak link is the socket. So if I don't have to replace your socket, I can just replace the ball. I think you're better off for the long term in the event that it is helpful. Here's a patient who lifted a lot of weights and unfortunately got involved with using steroids, and the steroids caused him to develop osteonecrosis or death of the bone on the shoulder. Here you can see I've resurfaced this shoulder, and this person went back to a very high level of activity, lifting weights and going back to a normal life. There are times we can actually replace or resurface just a little socket, just a little cap, and this is called a hemicap. And this is a ball and socket in the young person whose shoulder was dislocating, and we needed to replace that small defect. The shoulder replacements, when we go to hemiarthroplasty, so now I've gone beyond where I can do just a resurfacing operation. I've gone beyond where I can just simply resurface. I'm going to go and put a new stem in. And the stems, you can see, are getting smaller and more exciting. On the left side, you can see this long stem that would go all the way down the bone where we'd have to remove a lot of bone. And on the right, although this is a total shoulder replacement, if you look at the stem, it's much smaller. It really looks like it imitates or mimics the patient's native anatomy. And I think in the last decade, that's really been a transition of putting in a replacement to now restoring your anatomy as best as we can. A total shoulder replacement. Let me be clear, there's total shoulder replacement. When I can replace the ball and socket, is the best operation that I can give someone for pain relief. I get rid of their pain, I get their range of motion back, and they're extremely happy. But that being said, if I can avoid that in a 35 or 40-year-old, I'm going to give that 35 or 40-year-old a lot of pain relief, but a lot of function, and limit the need to come back for a secondary operation if at all possible. The reverse shoulder replacement, I put this in because someone's always going to ask me about it. I think outside of the severe trauma and failed multiple surgeries, we're going to avoid reverse shoulder replacements in the younger population. What's exciting and new? Well, we talk about cadaver replacement. We talk about recreating cartilage cells. Here you can see a young person's shoulder that's very arthritic. And here you can see, unfortunately, a cadaver shoulder with perfect cartilage on there. Is there any way we can use that cadaver shoulder to do a biologic shoulder replacement? And the answer is yes. We've started out doing small defects. So here you can see a person who dislocated their shoulder after a motor vehicle accident and ruined the back of the bone. That red picture with the shark bite of the defect out of it has been ruined. And the only way to help that person without putting a new metallic shoulder in them, and this is a 22-year-old, is to take a piece of cadaver shoulder, match size, match that defect, and fill it in for that defect. And from that concept, and then we screw it into place. And from that concept of replacing parts of the shoulder, we've come up with the idea of using a biologic shoulder replacement, where this person with advanced arthritis, instead of giving them metal and plastic, will take a size-matched cadaver shoulder and try and implant a new ball and even a new socket. This is very early. The indications of the people who are candidates for this are very few. But we wonder if this will bridge out our young 20 and 30-year-old patients who need replacements until their 40s or 50s, at which point we can give them more formal shoulder replacements. The future, looking at this, we'd like to avoid surgery in young patients who have arthritis. We'd like to try and do arthroscopy in those patients in whom we think it'll help, those patients with tight shoulders. If I can resurface the socket alone with an arthroscopic interposition, it's something I'm going to consider for you. If we put in a new ball, if I have to replace the ball in a young patient, I'm going to try and do it without a stem to preserve your bone in the event that I need to come back in the future and do a more definitive operation. The new ball and socket is a great operation. It works very well, but we're trying to hold off on it. And the cartilage ball and socket, this is the future. This is something that we're going to try and work on arthroscopically. I believe the future is here and it's now for the right select group of patients. So that's it for shoulder arthritis in the young patients. Thank you.